Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Welcome back to episode 18, I think.
Is it?
We do this every time, David.
Let's just say it's an episode.
It's an episode. To Unraveled, Understanding Complex Illness. I am Dr. Eileen Ruhoy, and I am with my co-host,
David Kaufman.
And
Hi,
so we are here to talk again about something that affects many of our complex and chronically ill patients, and that is sleep. Sleep is a big problem.
I think sleep is a complaint of every single patient.
Every single patient. And a lot of people, actually.
Yeah.
You know, in general, I think insomnia is widespread. I think sleep disorders are widespread. But it really does seem to play a very, I think, critical role in our patients and not only in their health, but even their recovery. Right? So they often report either difficulty falling asleep,
Right.
difficulty staying asleep, feeling like they're not refreshed when they wake up in the morning. So what do you
I
do?
mean, it's part of the prime defining criteria for ME/CFS.
Right.
So, yeah, it's a huge issue, and it's an issue. It's sort of a chicken and egg issue, not chicken or egg, meaning there's a sleep disorder, and that sleep disorder drives further symptoms of the underlying or overlying disorder. So
And
it
vice
makes,
versa,
right.
I think.
So
right.
it makes
yeah.
ME/CFS septad worse,
Yeah.
and it's driven by septad.
Absolutely.
So.
There's that connection, I think, that's like a chicken and an egg. What
Right,
comes
exactly.
first?
Right.
Sometimes when I take a history, I do get, we often talk about how patients will give a history of not only infectious disease many years ago, but even things like constipation, like some sort of dysfunction of some sort of organ system that had been present for years before, real, more objective symptoms presented. I very regularly get a long history of sleep problems,
Sure.
even when they were children.
Sure.
Yeah. So what do you do first when they tell you about their sleep?
I take a big, deep breath. It's really a challenge. Sleep
Yeah.
disorder is really challenging. And, the goal initially is always to try to avoid drugs. So I'll go over how do they go to sleep? What's their sleep, quote, hygiene?
Mm-hmm.
When do they go to sleep? What do they do before they go to sleep? All the sort of stuff we know
Yeah.
in terms of screens and food and alcohol, et cetera, et cetera. But I have to say most of the time I don't learn too much from that.
Yeah, but I do think it's important, and I think some patients sometimes feel a little like, my sleep hygiene kind of recommendations are not taking it seriously, but I'm actually taking it very seriously. And we know, and I always talk about the circadian rhythm of the brain. I mean, every cell has a clock in our bodies, right? And so we really are circadian beings. And anyone who's been my patient has heard me say this. We thrive on routine and rhythm. And our brain, more so probably than any organ system in our body, our brain, all those, every cell in the brain has its own clock, and they all function to work together to regulate what we refer to as the sleep-wake cycle. Right. So we focus so much on sleep, as we should, but there's also that other component of this rhythm that I refer to, which is a 24-hour rhythm,
Right.
and that's the wakefulness, right? So the wake cycle. And so, I always bring up the example, it's why, we put babies on routines, right? Because babies thrive in terms of their development when they are on a regular routine. And that's why there's a nap time and a bedtime and a feeding time,
Right.
and a bath time. And you develop bedtime routines, and we like to believe it because it just makes it so much easier for the parents, especially of the newborn. But it really is because babies thrive on a good routine.
Right. So, one of the issues with sleep with our patients ties into what you're saying, is not just I have trouble falling asleep. It's so often that their whole circadian rhythm is completely messed up.
Mm-hmm.
So patient after patient will say, I don't go to sleep till 5 in the morning and I wake up at 4 in the afternoon. And I say, well, why? Or how are we going to fix that? And it just happens, the way they describe it.
Mm-hmm.
And many have tried. It's very, very difficult. But that clearly feeds their illness or is not good for recovery from their illness. So I just want to make the point that it's not just a question of difficulty falling asleep. It's that so many of our patients have a disorder of their circadian rhythm.
Yeah, absolutely. And that's certainly been documented. There have been a couple of good articles about circadian rhythm disorders and ME/CFS,
Right.
but it doesn't really get to the sort of the core question, which is that, well, what causes it and why, and how does it potentiate the ME/CFS presentation and symptoms? And so I do think it's an important question, and I try to correct this dysregulation, and I do start with a lot of sleep hygiene recommendations. I do try to avoid medications, as you said, because sometimes that can make the problem worse. You end up with more problems than you started with when you start to try to pharmacolize, an abnormal rhythm. And the brain almost, it gets used to it, and then it relies on these medications. In fact, I have a lot of patients who are stuck on benzodiazepines because someone had given them benzodiazepines to help them sleep, or a lot of these sleep medications, which have their own set of side effects and concerns. So, sleep hygiene can be really important. I mean, we even do it for patients in the hospital who have dementia
Right.
or delirium, right? You raise the blinds early in the morning and you close
Sure.
the blinds at night. There's a whole sundowning effect where things just sort of get worse towards the end of the day. And it's because of this rhythm that the brain really wants, the brain really needs. And so the more that you can simulate it, and it does take time, certainly when there's a circadian rhythm disorder, it does take time. So it's, it's not like you do it for a couple of nights. Oh, it didn't work. I still can't fall asleep, or I don't fall asleep till 5 a.m. You really have to, be motivated and try hard. And I get that it's hard to do when obviously, you have a chronic illness, but I do think it's an important piece of it. I don't think it's the entire piece, of course, but I think it's an important one.
Right. So I think meds can help. I clearly have a subgroup of patients where I think sleeping meds, and in particular benzodiazepines, Ativan and Klonopin, help with sleep. I believe they help so well with sleep because it helps patients with their pain and their muscle spasm and their mast cell degranulation that may be going on at night. And that's okay. I mean, I'm fine giving a benzo if it works,
Yeah, no, I agree. I mean, obviously histamine is it's a transmitter in general, but it's also a neurotransmitter. There are histaminergic neurons. And as we know, antihistamines can cause somnolence. And so, we think histamine is part of the wakefulness cycle.
Right.
And a lot of mast cell patients will have too much histamine in their system when they're trying to fall asleep. So I do a lot of mast cell management before I go to the sleep aids, I guess is my point. And you're right, benzodiazepines are known to be mast cell stabilizers. So that's often a good choice when all else has failed with regard to trying to figure out a way of getting them to calm down. But it's important, the sleep stages are so important because, during some of the sleep stages, so first of all, each sleep cycle is about 90 minutes. We need about 4 to 5 of them in a night to really have restorative sleep. During some of the sleep stages that are more deep sleep, which are considered restorative and rejuvenative, is when the glymphatic system is most active, right? So how important is that for these patients? I mean, that is why I struggle so hard in getting my patients to sleep, because if their lymphatics are not working, they are not cleaning their brain, for lack of a better phrase. During the glymphatic function during restorative sleep, you have clearance of metabolic waste byproducts, of cellular debris, of abnormally folded proteins that happens in a body that has unresolved inflammation, right? So you need to clear it out of the brain. Otherwise, it just becomes more foci for inflammation. And then it's just certainly going to make the entire condition worse.
Sure. I mean, clearly will contribute to brain fog, which is a huge complaint with our patients, both in terms of the lymphatics and clearance, as you're saying, and sleep is a time when we solidify memory and experience. And
something that people don't realize is that you consolidate those memories if you sleep the night after you've made that memory, after you've learned a lesson. So, for example, for those who are listening to our podcast right now, if you want to remember what we're saying, you sleep well tonight, right? So that's actually how it works. You consolidate memories and lessons when you sleep the night after you've been exposed to that memory or lesson. But anyway,
and then you can see, in a patient whose every night is difficult, things just fall apart. They have brain fog.
They have
for
brain
one
fog,
of a better
right.
term.
Everything
is, they literally are in a fog. They can sit and talk to you, and they can sit opposite me like you are and talk to me like a, quote, normal person. But something else is going on, and if you ask the right questions, you can tease it out and really understand. I mean, some patients are obvious from the first moment, but most it's not obvious immediately. But the poor sleep habit, sleep difficulty clearly contributes to that, if not is a major cause of it.
And that's why they have difficulty with memory, though, because they're not consolidating those memories. And consolidation of memories, there's several phases of how that happens. Obviously, it starts in the hippocampus, but they are packaged. So during consolidation, not only are you cementing a lesson learned, but you also you package that memory, and it's actually moved to other parts of the brain so that you clear the hippocampus for more memories, for more lessons. And so that does not happen. And in fact, while a different topic, that's a very active area of research for PTSD, because they're constantly reliving these memories that are not packaged and sent elsewhere. But regardless, that none of that really happens when you're not having an appropriate amount of sleep, specifically an appropriate amount of deep sleep and restorative sleep. And that's just really important. And so I very regularly will order a sleep study for them. And I think a lot of people ask, well, why order a sleep study? They're telling you basically their sleep is poor. And it's not that obviously I believe them, but sometimes it's helpful to get objective data, on a polysomnogram.
Well, and some of it may be, good old sleep apnea, which is contributing to it.
Right, which is important, right? Because then now you have, so if there's sleep apnea, now you have hypoxic conditions during sleep. Right. So not only does the glymphatic system require, a good level of oxygenation, but so do your mitochondria, and so does sleep in general. And then, of course, a hypoxic state just induces, more inflammation, of course, and then an increase in abnormally folded proteins that then accumulate. So, because hypoxia-inducible factor is released when under hypoxic conditions. And if you have chronic sleep apnea, then you are basically allowing your brain to be in a state of hypoxia every single night. And that is just not a good way to be.
Not good. Not good.
So you're right. So a sleep study can at the very least identify if you have sleep apnea.
Which is something we can
and you could treat it, right?
It's actionable. It's treatable.
Yeah, which is nice because you would hate to miss something that's actually treatable, for
absolutely.
sure. But it also shows other things. I mean, it has an EEG component, so it's not a full EEG, which is what I like to explain to patients. So it's you can't rule out, epileptic kind of activity for sure if that is a concern on any level. A lot of patients will report sort of these jerk-like movements when they're falling into sleep, which is not technically epileptic, but they are, and usually benign, though sometimes not. But you can sort of pick it up on, some sleep studies, and the ones that you do at home don't necessarily have all this, but which is where what we do these days, especially with the pandemic. Of course, we're only doing them at home. But true sleep studies that were done in sleep centers and still are, even there's electrodes to like muscle groups and, monitors vitals. And so you can actually even see muscle movement because during certain sleep stages, you have basically muscle paralysis, atonia, as we call it. And some patients actually will wake during those stages. Some of these patients with a severe circadian rhythm disorder, they might wake during the sleep paralysis phase and they feel like they're conscious but can't move their bodies, and that's very terrifying. So there's a lot of parasomnias, of course, that are a whole area of neurology, and in fact, sleep is a subspecialty in of its own that's shared by both neurology and pulmonology. But I think what's of interest to us, of course, are the sleep problems that affect our patients and how we help them. So sleep study, I agree, I think is an important study to get because you can see, good old sleep apnea, which then we can treat. But you can also see if there's any evidence of one of these parasomnias. You can also assess like how long they're spending in each sleep stage and sleep cycle.
Right.
And I think that's important. And so, I always start with the sleep study. And then, so what sleep hygiene recommendations do you make?
So before I answer that, I want to just say something else. So again, a theme in all of these episodes is the interconnectedness of everything.
Yeah.
Okay. So a disorder of circadian rhythm is going to have some pretty vastly significant effects on the hypothalamic pituitary adrenal axis. Okay. So when we evolved to have our highest cortisol level in the morning, somewhere between 5 and 7 in the morning. If a person is sleeping till 4 p.m., everything is screwed up. And it's very challenging. How do you can't just fix that. I'm not even, and giving hydrocortisone doesn't fix that.
No.
And it's actually even challenging. How do we even measure it? So I do saliva cortisol levels on all patients. And one of the questions that comes up is, should I set the alarm and wake up at 8 in the morning to do the first saliva, even though I sleep till 4? And I'm not sure what the right answer is. Do I want this artificial 8 a.m. level, or do I want to see what they are at 4 p.m.? It's very confusing. And the point here is the sleep disorder messes HPA up. It probably messes thyroid function, TSH secretion. The whole hypothalamic pituitary axis is messed up, which only increases the significance of the illness and of the sleep disorder.
Well, and even more importantly, I think it's very much interconnected because it's the suprachiasmatic nucleus of the hypothalamus that controls the circadian rhythm of the brain. So it all starts at the hypothalamus, right? And so you're right. And then you have, an aberration of the whole HPA axis, and then your entire neuroendocrine system is, not functioning well. And so you potentially have increased sympathetic activity in the brain. So, the brain has nuclei that secretes certain, like norepinephrine, for example, right, which is noradrenaline for the brain. And it's supposed to shut down during certain stages of sleep. So there isn't this overactivation of the sympathetic nervous system. But that does not happen, as easily if you have HPA abnormalities. So, and circadian abnormalities. So it's so interesting. We used to think like there was one cell or one neurotransmitter that did, that had one function, that did one thing. We now know that there's so much interconnectedness between, the brain is, goes without saying, it's a very complex organ. It's a fascinating organ, and so I think that it's important to recognize that all of these things are related, which is why it's so hard to get to the core root of the problem, and why it's so hard to treat, and why every patient is individual, right? And every patient responds to something different, and we have to tweak it as we go, and which is why we always talk about the journey that we take with our patients, because we just sort of, based on their feedback, just work with what's our best next step to help them. And so I really focus a lot on sleep hygiene, because I do think it's important to try to bring back that circadian rhythm as close as we can. And I just very regularly recommend, going to bed at the same time each night and waking up at the same time each morning. And they will very commonly say, I won't ever fall asleep if I go to bed at 10 p.m. And I say, that's okay. Just lie there, And so because I think that we have to start to at least let the body and brain know that this is now the time that I should be falling asleep, and there's no other way to do that other than, I have them set up some sort of bedtime routine, whether it's, a warm bath, a warm shower, some meditation, some deep breathing, which we know can basically be a self-directed parasympathetic invoking activity, and then just sort of lay in bed, basically. I give them, I sort of guide them through some more relaxation kinds of techniques. And I don't expect them to fall. If they've been going to sleep at 3, 4, 5 a.m., I definitely don't expect them to fall asleep at 10 p.m., but I want to start telling their body and brain that this is how it should be. And I know it's a struggle, but I do think it's important. And then I say to wake up and get out of bed at the same time each morning. I talk about going out for morning light in the morning because,
light
the
is
angle
a huge
of the sun.
Piece of
right. I mean, people don't recognize how important the where the sun is in the sky between like the hours of 6 a.m. and 10 a.m. Although here in Seattle during the winter, I don't think there's any sun till 10 a.m. But, the angle that the sun is in the sky, that how it sort of reaches our optic chiasm and then into our brain, sort of gives the brain a notice that this is a brand new day.
And the flip, the flip of that at night, if you have lights on or a screen, it's going to mess you up.
Absolutely, it does. And there's a lot of studies that support that, by the way. We have too much light.
Our patients they're in a difficult position. Okay?
I know.
Many of them are not able to kind of get out of bed and go outside into the light because they don't feel well enough.
Right.
So that's strike one. Many of them, all they can do really is screens, look at their screens. I mean, spend enormous amounts of time on the computer, on their phone. So we're basically saying, well, you're going to have to stop using your screen at 8 p.m.
Mm-hmm.
That's actually a huge issue for them. So it's more complicated than just good sleep hygiene. It's taking away the few things they have left. I
know. And I absolutely acknowledge that while I say it. And then I say, but I like to lay it out.
Yeah, I agree.
And I talk about just going out and sitting out in a chair outside your door on a porch, and I go over what their obstacles are. So I lay it out for them, and then I say, okay, now you tell me what you feel would be impossible for you, and let's figure out a way to get this done. If not today and tomorrow, then maybe 2 weeks from now or a month from now. And again, it's why it takes so much time with patients, but it's fruitful, because I think it's critical, to really try to remind their brains of where they need to be. And you're right, the screens are a huge problem. I mean, so to really get optimal sleep, you really need to be in darkness, and you need to be in silence. We know that because there are certain sleep stages that you're easily arousable, and so if there's any kind of noise, you can easily be aroused out of sleep.
Right. I mean, it's a cultural issue too.
It's a
I mean, I like to read before I go to sleep, and as I'm listening to you and thinking about it, I tend to read on an iPad. Well,
yeah,
I'm breaking a rule.
My
That's
husband does that. I read only books.
Yeah. So it's very difficult. And for our patients, if they're going to read, most likely they're going to read on an iPad as well. Oh, it's a real challenge. Have you used any of the artificial light sources to help?
I have not. No.
Yeah.
No. And I tell people to use an eye mask so that they're in complete darkness.
Right.
And I don't do the earplugs. I think that for some reason, I feel like they're uncomfortable for patients. But there are some gadgets these days that have things that sort of cover the ears,
right.
Some like wraps that cover your eyes and play music in your ears. And I don't think it has to go that far. I think that if you can just
find
I don't think
that's why they're not falling asleep.
No, either do I. But again, it's just... It's a matter of it's basically like limbic retraining, right?
It's basically what it is.
It's basically just training the brain, and that's how I try to emphasize what these recommendations that I make, because I don't want it to sound like I realize that that this is easily done for them, but it's so important, and in the long term, it's really important. So we have to start somewhere.
Yeah.
Right. And so I do that. So, obviously I have them on a lot of mast cell meds that I'm trying to decrease the histamine to begin with. Sometimes, or, more often than not, they're already on benzodiazepine, so they already have that on board. Tell them to take it at night. Low dose naltrexone actually has been very helpful.
Right.
I definitely am a fan of melatonin. There's a particular peptide that I like called Delta Sleep Inducing Peptide that I think has been very helpful for a segment of my patient population. So there are a couple of, certainly oral med/ supplements that I use to help support sleep. But I think sleep hygiene is sort of where, in the long term, that's where, the money will be.
Yeah, I mean, I think another cause for the sleep disorder is built into the illness. We sleep better if we exercise.
Yeah, that's
and
right.
Our patients can't really exercise. I think it makes a huge difference. I can tell
Right.
myself, if I'm traveling and missing my workouts, I don't sleep as well.
Right.
And
No, it is interesting to me, and I've often thought about, again, the connection about what comes first, right? So, because as you know, the chronic fatigue component, the post-exertional malaise, we talk a lot about that. Like, why does that exist? And there are a lot of theories. I think a lot of theories hold a lot of weight. One of the theories that I've once sort of entertained is this idea of, that with patients with sleep disorders, there's elevated adenosine. And adenosine is a marker of energy depletion. And so I wondered if we did a study of adenosine in our patients to sort of see, which it's a breakdown of ATP, of
Right.
course. So that's why it's a marker of energy depletion. And so I wonder, we haven't done those kind of, biomarker workups for the chronic fatigue, at least none that I'm that familiar with that have been, sort of robust and widespread.
Right.
But I think my point is there's a lot of things that we can study about why. And then the other theory that I had, just because we were talking about sleep, is that, there was a study that sort of showed that when there's chronic activation of the cortex, the muscles, especially of the motor cortex, the muscles are in constant state of activation, which is very energy draining. And so any additional movement of the limbs would create this sense of overwhelming, like fatigue and malaise just from the minimal exertion itself. And I think about its relation with sleep, and I was talking about how you can have excessive or rather lack of shutdown of the production of things like norepinephrine, and these things would be a sympathetic trigger of the cortex, and so you have cortical activation. And so I think I'm rambling a little bit, but I'm trying to bring it back to the connections that I make in my head about why we have chronic fatigue.
Well, as many patients will say, I have the wired, tired feeling.
Right. That's exactly my point.
This very, very frustrating for the patient and for me as a physician, because I think I understand what they're saying and experiencing, but I don't have an easy answer for that. And I think part of what you just were describing relates to that
That's exactly right.
situation.
Right, because we know they have autonomic dysfunction.
Right.
I mean, I will say, and we talk a lot about the septet patient, And, a lot of times we get questions, about, well, how do they all connect? Like, what's the common denominator? And there are answers to it that I think are true, but I think there's just it's so deeper than what we know.
Oh, yeah.
And that's why I think trying to make the connections about why they present a septad is so important to us. Which is why I come up with all these theories, which, again, to be clear, these are all my theories.
Well, I think we both do that. We all try to do that.
I know.
We need to try to figure it out. And, I often will tell patients, just as a general statement now, not about sleep, everything I'm doing is to a great degree trial and error, titration, tweaking. It's all based on feedback because we just don't know enough.
We just don't know.
At least we know there's a problem.
Right.
And at least we know and have identified various pathologies, which we understand now, or at least our group, so to speak, does in terms of the septad and how they're all interconnected and bidirectional. But we don't understand the why of that, and so we end up having to do trial and error experimentation.
The why plagues me, though. I lose sleep over the why.
Yeah, of course. Me too. Me too.
So I think these kinds of dialogues are important, and maybe our podcast is not the place for us to pontificate on theories, but I think it's important. I think it's interesting, and I think our listeners, like to hear that what we're thinking about. But back to more sort of practical approaches. I think just going back to what we had said earlier, which is again, the focus is on sleep, as it should be, but also we need to focus on the wake part of the cycle, right? Because we're trying to set up this 24-hour rhythm.
Right.
And focusing on the wake portion of our cycle can actually go a long way into helping the sleep part of the cycle, right? So it sets you up, which is why I use the babies as an example, right? So I always tell patients, however you can, whatever the routine is of your day, keep it a routine, and whatever that may be. And of course, we know there's a severity of disability in this patient population in terms of what they can and cannot do. We have patients that are bedbound, we have patients that are housebound, we have patients that are able to go to work, but then they come home and obviously they're just completely spent and fatigued. So there's a severity of what they can and cannot do, even in terms of activities of daily living. So I always say, whatever it is that you are able to do or able not to do, make it into a routine during the day, and whether that means meals or bathing or a certain activity of daily living like dressing. If you can make it at the same time each day, just so it simulates a routine of sort. Certainly, again, open up the blinds, make sure that you're getting out light inside the home, so that there's a distinction between darkness in the home and light in the home, to at least your body and brain. I think these little things that certainly can be done can, again, in the long term, make a big impact. Do you agree?
Totally agree. Of course I agree. So you had asked me a question a little earlier about moving on to treatment, and I, of course, digressed and diverted. So why don't we talk about that? Yeah. So sleep hygiene and everything we've been talking up till now, and then if that's not helping, or in addition to that, not in place of or instead of, are there medications or supplements or other interventions that might be helpful? So, as I said, I do think benzos can be helpful. I have some patients who do great just with plain old-fashioned Lunesta, which is a sleeping med. It works for a lot of people. And then there's another medicine I've seen help a lot of people is trazodone.
Oh, trazodone is definitely the one I use most commonly.
Sort of a go-to med. It works without significant side effects.
Well, and it's non-addicting, so I like that about
that works
trazodone.
Well. I think one of the key things to understand here, and this may be one of the whys, we talk about ME/CFS and Long COVID as a neuroimmune or neuroinflammatory illness, the emphasis on the word neuro and inflammatory. So are there ways to reduce that inflammation? In other words, I think we believe that part of the circadian rhythm disorder and the sleep disorder is as a result of inflammation. We don't have to talk about why there's inflammation for a minute. We'll leave that on the side. So what interventions might help that? So the classic go-to day one for me is low-dose naltrexone. Mm-hmm. Ironically, the only significant side effect of low-dose naltrexone is it can interfere with sleep because it causes vivid dreams.
Right.
However, many patients say they sleep better than ever. And I've almost never had to stop the drug for that reason. Either it disappears, which is the usual case, that's why we taper it up, or they can take it in the morning and get similar benefit, although we think it's more effective at night. But it is a true neuro anti-inflammatory drug.
Oh, I completely agree. My theory about the vivid dreams, and it's true that they do get better,
Yeah,
is that these patients are so sleep deprived that they're finally getting into
exactly.
REM state.
Right. They're
Yeah,
making up for lost dreams.
yes, exactly. I mean,
Yeah.
that's the only way I can put
Right.
it, right?
I agree.
So sometimes I actually tell them that those vivid dreams are a good sign,
Right.
because they're recouping sleep. Though,
Well, and a lot of them love it.
Yeah. Oh, I know.
Yeah.
So I always tell them it's sort of a good sign, and they're generally not nightmares. They're just very vivid, and I think it's alarming to patients at first that all of a sudden they're having these very vivid kinds of dreams. Although occasionally they border on nightmares, and so
Yeah,
that's a concern,
right.
of course. But I always tell them it's sort of a good sign that they're making up for sleep a deficit. Though science will tell you that you can't really recoup lost sleep, but I think to some extent you can if you've been chronically sleep deprived. At some point,
Right.
your brain will just sort of thank you for it, basically. And those synapses that are coming together to design those vivid dreams are like, they're like old lost friends, like
Yeah.
finding each other again, and they're like hugging really tight, and so that creates a lot of electrical exchange that I think are responsible for
Right.
the vivid dreams but they do get better, and I always tell patients that. And I've had the rare patient that say they're just too disturbing to them, and so then I do what
Try it in the
you've
morning.
said.
Yeah.
I put them in, and I put the dosing in the morning.
But I think it's key to understand for physicians
Mhm.
and for patients, LDN is working because it is literally decreasing microglial inflammation.
Yeah.
And that's such a powerful concept or understanding, because it just supports this whole notion that the root of the problem is this neuroinflammatory illness, which is driving everything else. I mean, probably maybe that's what should be at the center of the septet, a little
Yeah.
brain with lightning bolts or something.
No, that's a good point.
You know?
It's astroglial
Yeah.
activation is really what it is.
Yeah.
That's interesting.
So I've never, I'm thinking as I'm talking, I've never tried doxycycline or minocycline for sleep disorder, but both drugs are similar to LDN in terms of reducing neuroinflammation.
I've never used minocycline. I mean, I've used it occasionally, but I definitely use doxy a lot. And patients have reported improved sleep,
Yeah.
though that wasn't my indication
Yeah,
for it.
I'm going to
That's
try it.
interesting.
It's just got a new idea.
Let's
Thank
do
you.
Do you do the low dose or the high, like the?
For doxycycline?
Yeah.
Well, I haven't tried it yet. I just literally, as I'm talking here,
so,
thinking
right,
maybe I
that's
should try that for sleep.
Are
it's
you
an
thinking
antibiotic.
about the low
so
dose, or are you thinking about the
Oh,
higher
I
dose?
see. I'd probably start low and see.
That would
The
be
downside
interesting.
is it's antibiotic, so it's going to affect the
Yeah.
microbiome, et cetera, et cetera. But it's an interesting thought.
Yeah, I think there's a lot of things to consider when you think about all the reasons for the sleep fragmentation in ME/CFS patients and other patients with, including long COVID patients, which also are reporting
yeah.
horrible sleep. I mean, horrible sleep. And so, again, trying to correct sleep, I think I can't imagine recovery without good sleep.
Right.
Because sleep is so critical to who we are as humans and how our brain functions and how our brain works. And we actually know just on a conventional basis that poor sleep contributes to neurodegenerative disorders. And we know that because there's accumulation of these proteins when you don't have glymphatic function, when there's hypoxic milieu, these proteins are allowed to misfold, and our corrective systems are not functioning, and so they're not being unfolded and refolded in a proper manner, and they accumulate, and then they cause neurodegeneration. And so I think it's key, and I think we should probably be doing more lumbar punctures and looking at CSF fluid and seeing what markers we can find.
This from an EDS expert?
In a safe manner.
What are your thoughts on cannabis and CBD?
I have to tell you, I think I don't regularly recommend it or prescribe it, only because I don't feel like I'm an expert in it.
Right.
So
Same with me.
it's not that I'm against it, and I usually defer to those who are experts, and I have a couple people that I just refer to because I trust their opinion. But I will tell you, when patients come back and I say, how's the CBD working? It's like 50-50.
Right.
Some say it didn't work, some say it works great.
Yeah, that's my experience.
Yeah.
So I think it's a sort of a vast area that we don't understand.
Yeah.
Because we haven't been able to study it. And I'm like you, I don't know how to prescribe it. Plus, I'm not sure how to be sure that the quality and the replication of that quality is going to occur.
Right.
it
You mean any
seems to-
edibles?
Yeah, I mean, it varies by source, by store or company.
Mm-hmm.
It probably varies, obviously, by absorption.
Yeah.
So that's a challenge.
I think those endocannabinoid pathways, it's a hard word to say,
Right.
at least for a New Yorker. I think they're fascinating, though. They really are.
Yeah.
You know, we have endogenous cannabinoids. How do you say it? Cannabinoids. Um, and so we have endogenous compounds that work on that pathway that are seemingly they're what I understand is that they're overwhelmed when you give exogenous forms. So it shuts down any endogenous pathways that we have that are meant to basically induce a parasympathetic response, to control sympathetic responses for sure of the neural pathways. So I've not ventured into the CBD cannabis
Maybe
world
we can
just
find
yet.
somebody and bring them on who's got a lot more experience.
That's a great idea.
Be really good.
I think on our listserv there's a bunch of experts.
Another medication I use with some good results is cyclobenzaprine, Flexeril.
Mm-hmm.
So it's a
For
muscle.
sleep?
Yeah, it's a muscle relaxant, but it really helps people sleep. Probably because their muscles, going back to what you were describing with the activation and et cetera, that it's helping with that. The low dose, like 5 milligrams, even 2.5 milligrams.
Nice.
Yeah.
I haven't tried that one yet.
Yeah.
I do a lot of hydroxyzine.
Yeah, I do hydroxyzine too, but I find a lot of patients feel hungover in the morning from that.
Well, I do tiny dosages.
Like 10, 5?
Yeah, well, I prescribe the 25s. I tell them to take a quarter of that.
Okay.
So what's the math? So 12.5 divided by 2.
6.25.
6.25, yeah. Right. So I do really low dosages, and then I titrate up. So if it didn't work at 6.25, then I do 12.5. Right. But I find that hydroxyzine can really help. I mean, Benadryl helps a lot of patients as well, but and that's easy and it's over the counter.
Yeah, exactly.
So yeah, I mean, there's a lot of different, I think, drugs that can help induce sleep. But then I wonder how natural that sleep is, right? And I know that when you're not sleeping and haven't slept for weeks, months, years, any sleep they'll take. So I initially I don't really care. I just want to get them to sleep, and I want to get them to sleep at better hours. And in fact, we know that first sleep cycle, if it's not at between 10 and 11 p.m., this is what science has shown. It is not restorative like it should be. So even if you first fall asleep at 3 a.m. and that first cycle is not the same cycle that you would have gotten if you had fallen asleep at 10 p.m.
I'm in trouble.
And I know you're a night owl. I know.
I'm in trouble.
And night owls get really mad when I say that.
Although I have started
you
going to
eat
sleep
too
earlier.
late. That's your problem.
I'm from New
That's
York.
the other thing. I'm from New York.
So I'm going to ask you a question. Okay, I just actually today,
I'm a Brooklynite.
just before I came here, was listening to a Peter Attia podcast, and they were talking about sleep. And he was going into everything you're saying. If you shouldn't eat late, and it's bad for your sleep, et cetera, et cetera. And I know that, and I understand that. However, what I don't understand
is
what happens.
Just so listeners understand, when David and I try to make dinner plans, I try to go at 5. He wants to go at 8. So we come somewhere in the middle.
It's the West Coast, by the way. Everybody here eats so early. It's incredible. But if that were true, what about Spain and France and Portugal, where they don't even consider eating until 10 o'clock at night? Is there an epidemic of sleep disorder there?
I don't know. Maybe there is. Or maybe there's an epidemic of other neurological problems and cognitive issues. I don't
know. Haven't heard it.
It does bring us to intermittent fasting in a weird sense.
Yeah.
And I know that's not the topic of this podcast, which I think it should be a topic. It's fascinating science on that too. But I always say that, it's easy for people to skip breakfast and they feel like they're intermittent fasting, which again, you take what you can for the most part when you can, but it's best to simulate our circadian rhythm, which really is meant to we're supposed to stop eating earlier in the day. And so that's why you should not eat late, because you don't want to go to bed with foodstuffs still in your GI tract that needs to be digested and metabolized and absorbed and assimilated. I mean, that takes a lot of energy. So you're taking energy away from what needs to happen during sleep, meaning brain regeneration and brain cleansing and, the rest of the organ system resetting, because now all the blood is being diverted to the GI tract in order for it to get rid of the food that you put in it right before you went to bed.
I get it. I am eating a little earlier, but not at 5 o'clock.
I try to stop eating at 5 p.m.
Oh my gosh.
I know. It sounds sacrilegious. But yes, so you also can't eat late.
Right.
As another part of this sleep hygiene recommendation that I very much recommend.
Yeah.
For
No,
sure.
I agree. I mean, I know that. And I'm not a great sleeper. I should confess.
I will also say, just just speaking about my own personal experience, that when I stopped eating, I used to eat a little bit later than I do now. I sleep so much better when I stopped eating at 5. I sleep so much
We're
better.
never going to get to go out to dinner.
I make exceptions for people that I like to go out to dinner with. But my husband gets home from work so late, and he eats very late, and then he can't fall asleep. So I do think there's something to it.
That's part of where this happened for me. During training, residency, internship residency, and
but
work.
that was years ago, David.
No, but I would get home late, and I'd want to eat with my kids, so the kids waited. And so we ate late.
All right, well, now it's time to fix that.
I can't do 5 o'clock. It's not even possible, especially now in Seattle when it's light till 10 o'clock. I'm sitting there on the couch at 7 o'clock and suddenly realize what time it is. I haven't done anything yet for dinner because it's beautiful out. I'm like, you don't eat till it's dark. Who ever heard of eating when it's this late?
You see, that's the other thing. It's hunger cues, right? So people aren't listening to hunger cues anymore. And you have to, so if you're not hungry at 7 o'clock, then don't eat. The problem is you're going to
get hungry at 8.
Then just go to bed. It's okay to go to bed a little hungry, you know.
No, I
In fact, it can be healthy.
Yeah, I get it.
Okay, well, we are out of time. So we sort of ended on our own personal I know. But sleep hygiene is important, and I think sleep, in general is a very interesting topic, and so much more to say about that with regards to just sort of what sleep is and its function and how important it is to our overall functioning and our overall health status. But certainly sleep is a problem in our patient population, and we work hard. And I will say the last, medications, just, in general, while we try to avoid them, I always say that sometimes it actually helps just to get the body and the brain to remember what sleep is, right? To remember what a rhythm is, learn what sleep feels like, get back on that horse. And then over time, when the body sort of knows what sleep is again and what a rhythm really feels like, actually, sleep seems to come back at certain points along the way.
So I know we're ending, but we didn't address things like caffeine and stimulants that many patients take during the day, which may interfere with sleep. So maybe another time we can get into that.
Well, we'll definitely do another session, sesh. All right. Well, thanks for listening on our conversation about sleep. And again, go to our Patreon page, ask all the questions you want. We really like those questions. I mean, it's really fun, actually.
Yeah,
it's very active on the Patreon page. So we appreciate it, and we'll see you next time.
Thank you.